Hi everyone, welcome back to Around the Room. I'm Daniel Ennis. This is another episode of Ask an Expert with Dr. Janet Pope. Last time we talked about diagnosis and investigating scleroderma. Today is scleroderma part 2. We're going to be discussing management. If you have questions or comments, please get in touch through the CRA Twitter account or by email. And we usually announce the upcoming topics in the CRA email blast, so keep an eye out for that as well. Janet, welcome back. How are you?
Good. How are you?
I'm pretty good. Thanks very much. So since our last conversation, I was actually really looking forward to this because I think scleroderma can be pretty scary. And if you don't see a ton of it in clinic, it can be quite overwhelming in terms of what do I need to treat? Why do I need to treat it? What's the outcome I'm looking for? When am I going to stop? And so I really wanted your help in terms of kind of finding my way through that thicket. So maybe the way that I was thinking about talking about it is we're going to kind of go organ by organ, and I can get your pearls on each of them. And so maybe first thing to do, because it's kind of the first thing that I see when they walk in, maybe we can start with skin. So when do you need to treat skin, and what do you use to treat it?
So, Daniel, it's $1 million question because we don't all agree. But in general, the data would all be in the diffuse cutaneous systemic sclerosis, so the diffuse subset, whereas there's really no randomized trials of treating skin itself in the limited. And so we tend to think you would try to treat when you think it's active and there's some degree of reversibility. So in early diffuse, when we're giving immune modulation, it's probably for the skin and or things like early organ involvement like lungs. And so when we're treating it, it's early on, but should they be on that treatment indefinitely? That's really tough to say. And you're expecting a change many months out. So it's not like methotrexate and RA, as we all know, where we're going to see methotrexate taking effect fairly quickly.
Mm-hmm. And so to that end, you mentioned you want to treat it if and when it's active. How do you tell clinically that someone's skin is actually active?
So early on, the patients that feel their skin's warm, like their hands are cold from Raynaud's, but I often say you can fry an egg over their forearm if it's really hot or warm. Often it's itchy because they have edema and they have histamine granules and other things. Mast cells are active in the skin. So heat, presence often, but not always, presence of tendon friction rubs. The change, so it's you look at the delta in skin score. Oh my, they were last time just beyond their wrist proximally, and now they're almost to the elbow. So you go, that's a big change. It's active. It's rapidly progressing. But I think anybody who's presenting with a history that it sounds like it's early and they're in a diffuse subset, I think anybody could warrant a trial of an immune suppressive because it could be active. But when they're all 10 years out, not all patients, but when a patient is 10 years out and hidebound, the skin is cool, you don't detect real inflammation when you're examining, no tendon friction rubs, not warm to touch. Those sorts of patients, I'm not so certain that they would respond at all to our traditional methotrexate, mycophenolate, mofetil kind of meds.
And further to that, then, does it matter to you if the skin is completely bound down or it's kind of early, lower grade, modified Rodnan skin score, even if diffuse? Does the degree of the scleroderma actually influence the decision to treat?
Well, I think that it influences the prognosis. People less severe might get more responsivity because they're not already sort of glued to their subcutaneous tissues.
Right.
But the location, if once you're either above your elbows, above your knees, or truncal, so in other words, diffuse, or there's not many limiteds that actually go to mid forearm. So if the patient's already like from fingers, hands to mid forearms, I'll probably treat them saying you might be diffuse, and we have to, instead of waiting over time, just get on with treatment. But you are right on prognosis that if someone's really hidebound, it's not a good predictor. And we looked many years ago as a sub-analysis of our methotrexate trial, and also looked at the old D-penicillamine trial, which was negative. But we looked at on equal skin involvement, who was more apt to do better. And I guess not so surprisingly, you were more apt to improve if your HAQ score was lower, probably because it was, although the skin was involved in the same areas, the skin score was in fact even the same because we matched for that. But they still had good enough function, which maybe means it's still the depth was different.
Okay, gotcha. So you mentioned the major treatments that you use, so methotrexate and mycophenolate mofetil. Typical doses as for other diseases? Anything special we should know there?
Right. So what I can say is the trend, particularly in the U.S., is more going for mycophenolate mofetil in early diffuse, trying to get to 3,000 milligrams a day. Why that over methotrexate? Because it has the data of scleroderma lung study 2, which we'll talk about lungs later, but where it is relatively helpful on average to the lungs. And because a lot of early patients who are going to get lung involvement, they do get it early on as opposed to later. It might be way worse later, but they often develop it in the first many months of disease. And for methotrexate, often targeting the trial that we did was up to only in those days 15 milligrams a week, which is now we would think very low dose. And Dr. Vandenhugen and his group, when they did their methotrexate trial, they were 15 and the occasional patient was on 30 milligrams. But the traditional wisdom now, which would be anecdotal, not proven, would be 25 milligrams once a week. And just as a pearl, mycophenolate mofetil isn't all that great on skin. So scleroderma lung study 2, 2/3 were diffuse, 1/3 was limited. So limited probably aren't going to change their skin score, right? But in that 2/3 group that where the skin score might change, cyclophosphamide, which we don't use traditionally at the beginning of immune modulation, but oral cyclotimes 1 year and then nothing, was twice as good on skin improvement than mycophenolate mofetil 3 grams a day for 2 years. So don't think ever that we're going to get these giant responses because we're using what guidelines are suggesting or what some clinical experts are suggesting.
Okay, interesting. Okay, so that gives us a sense of skin, and maybe we'll kind of touch on biologics and which biologics are valuable for skin kind of as we get to the lungs. Maybe we'll move on then to a different organ. So let's cover kidneys. So I know you do a lot of service at the hospital and you take care of a lot of scleroderma renal crisis. So I'm wondering how you approach the management of that.
Right. So we do have to have a high index of suspicion. And it's funny when you say a lot, scleroderma renal crisis is very uncommon. So in any year, as seeing a lot of scleroderma, I might see 0 to 2 patients with renal crisis, whereas I probably see not all new, but I probably follow 300 or more scleroderma patients. So just in scleroderma renal crisis, uncommon, but the phenotype is early, diffuse, more in men than women, rapidly progressive, often, but not necessarily, already having other organ involvement, such as pericardial effusion. Usually a cardiomyopathy isn't diagnosed yet. And then they might also, but not necessarily, have ILD. They might have pleural effusions. So they look like they're rapidly progressing. If they were unlucky enough to be given glucocorticoids because their skin's so hot, they can't function to get dressed, things like that, prednisone is a risk. So those are the kinds of patients. And of course, almost all of them are RNA polymerase 3 positive, but that isn't available in many of the ENAs. I think in Calgary it would be, but in a lot of our other institutions it isn't. And then when we get to treatment, number 1, get the blood pressure down as quickly as possible. Number 2, if you don't, and or if they present with renal impairment, they do worse. So not getting the blood pressure under control rapidly is a poor predictor, no kidding, of renal impairment. And having renal impairment already is a poor predictor. So starting ACE inhibitor, so The traditional data were with captopril, and it can be BID, TID dosing. So if you want to start at 6.25 milligrams, then start it. If their blood pressure doesn't crash, which by the way it won't, they make it TID or QID. I often just start more at medium high dose and change it to BID dosing to get maximum dose on day one.
Mm-hmm.
And then nephrologist will say, oh, their creatinine's going up, you have to stop it. And it's like, well, they don't have renal tubular problems, or they don't have renal artery stenosis. This is scleroderma renal crisis. This isn't malignant hypertension and malignant hypertension on top of normal essential hypertension. You want to make sure that they perfuse their brain as you're going down on their blood pressure. For scleroderma, that patient most likely had a totally low normal or normal blood pressure last week. So you want to make it very fast. When you do the ACE, I often use as well enalapril because it's available in every formulary, 5 BID and up to maximum dose within a day, get to maximum dose. And then whatever ACE it is, and not an ARB as first line. So ACEs work because of they lower renin, but so do ARBs and so do beta blockers. ACE inhibitors work because they vasodilate, they improve bradykinin, and that seems to be what saves lives in renal crisis. So ARBs don't work. So if you add an ARB on, sure, why not? I wouldn't bother, but I'd add something else, and I'll get to that. But you can do an ACE at full dose from the beginning. Then you can do whatever you want to get it down. Labetalol, alpha beta blocker, calcium channel blockers, intravenous drugs, whatever else you add to get it down is great. And I just, the other sort of clinical pearl is a lot of them are wet because they have a pericardial effusion, they have maybe peripheral edema, but they're dry at the kidney levels. Those kidneys, the arteries are in extreme spasm. So you don't want to dehydrate them. So even if they have total body water up, their perfusion is probably low. So I have an IV in them, usually both arms, and you want to just watch fluid balance. Most of them had hearts that weren't going to go into heart failure because the renal crisis is often early on in the disease, but just watch that and watch their potassium. It might go up because of the renal failure.
Okay, so captopril or ACE inhibitor up front, push the dose, be aggressive up front, and you can always reduce it later. And the second agent, you're not too fussed about. The second agent is really, it's not about mechanism. Second agent's about actually getting the blood pressure down.
Absolutely.
And do you have any particular targets that you aim for with your blood pressure control? Or do you look at what their baseline was, get back to that?
Right. So it's interesting. Marie Hudson did a study, and because she's very interested in renal crisis, and she found something like, and if I say a half, maybe it was a third, but a third to a half had a documented blood pressure on their chart before, because some people, this is how they present, and they weren't at the doctor for 2 years. So many of our patients don't have one charted, but if they do, and it's recent, that's what I'm aiming for. So if your blood pressure was 110/70, that's what I want. And I think of it like pregnancy-induced hypertension. We want a pregnant mom, not a renal crisis mom, like just a regular pregnant mom who has high blood pressure. We want to target it to their normal low blood pressure that they had before that occurred. Same idea. You want to target to what was their normal blood pressure in the recent past.
Okay, great. All right, so we got skin, we got kidney. Next, we're saving kind of lungs for the end. So next, let's talk about GI. And we kind of went through each individual problem last time, and in terms of investigations, and we'll kind of do the same for treatment. So we'll start easy and get harder. So acid reflux or GERD, how do you typically manage that?
So almost everyone has it. So if they're not complaining of it, I still think they have it, but it's probably subclinical. So it's almost 100%. So with that in mind, I'm very freely prescribing PPIs. And in general, whatever PPI is reimbursed for the patient, use and double it. triple it, and many can be quadrupled, even though the approved dose is usually once a day and occasionally twice a day. There's very few, in fact, probably only one, and I'm going to forget, but I think I'm going to forget which one. There's only one that after triple dose, it's probably a flat equation of getting more bang for buck. But so you can exceed the dose. So often, if it's a omeprazole 20 milligrams a day, then, in a few weeks, if it's not helping, it's not an emergency unless if they have severe erosive esophagitis, can't swallow, can't eat, but you're going to double it fairly quickly and get symptom control that way. And with any GERD, you want to have them not eat after supper, raise the head of the bed, and avoid triggers. So the triggers, everything that's good, like alcohol, chocolate, caffeine. If that triggers peppermint, avoid it. But for a lot of scleroderma patients, the trigger is having scleroderma because their whole tube is like a lead pipe that doesn't contract, and the bottom of the esophagus valve is lower esophageal sphincter is wide open. So they're just like freely refluxing upwards. So they often don't have too many food triggers, but if they do, try to avoid that. Raise the head of the bed for sure. We don't want lung aspiration.
Right. Okay. Then next, how about dysphagia?
So that's a tough one. So usually I send them to GI. So I don't order manometry. We talked about that before, but if GI wants it, sure. But we treat them clinically. If food is sticking, can GI dilate? And the interesting thing about scleroderma dysphagia is sometimes it is a stricture from reflux esophagitis. You start getting tissue buildup there, and they can crack it open, and patients are happy again until it eventually recurs, because they're going to, if you're that badly off, you will continue to get some degree of reflux and scar. But
Right.
for some of them, it's just purely dysmotility. And interestingly, sometimes when you dilate, you will actually get improvement, even though there is no stricture. So I send them off to GI. And then with dysphagia, chewing your food, water with you. A lot of them avoid the dry foods that stick, and just think of anything that might stick. If you're eating with a rush, that's the foods that usually someone with scleroderma doesn't like. Then I might do a promotility, and I will still treat acid reflux because some of it might be exacerbated by erosive esophagitis or just even low-grade erosions. It's not going to help the situation. So promotility, whether it's domperidone, 10 to 20 milligrams up to QID, and I write aware of Health Canada's recommendations, and the recommendations are don't go to that dose and don't use it long term. So I'm aware of that. And if you're going to do domperidone or high dose metoclopramide, you do order an ECG because it keeps the world happy. You can get a prolonged QT, which is true but very uncommon, but it's an easy thing to do. If I have a patient on 20 QID of domperidone, I do order occasionally / rarely an ECG. And then if not, Risatram, which is percoloprolamide, which I probably said wrong. That's cisapride's cousin. Cisapride's off the market because it had one metabolic pathway, so you could get a prolonged QT more likely on that. The Risatram has two metabolic pathways, so it doesn't seem to prolong QT, at least in a really scary sort of way, and therefore we can actually use it, but it's not approved for that. It's approved for irritable bowel. But it's a really good promotility, and it's possibly, without a lot of studies, possibly as good as, if not better than, the other ones I talked about.
And can any of these be combined together, or do you move from one to the next?
Right. So for the promotilities, I don't put two on together unless if it's really severe. And if it's that severe, like where you might use domperidone 4 times a day and metoclopramide at nighttime. If it's like that, I have GI involved because honest to goodness, you don't want a bunch of drug-drug interactions. But do I have a few patients that are on maybe even like 2 or 3 promotilities? Yes. But they're also on 3 or 4 times the dose of PPI. So they're usually on an H2 blocker at bedtime because that's the severe acid reflux, even if you don't have dysphagia. Those patients rarely might need a surgical procedure like a modified Hill or Neeson, but then it's a problem because they already have a lead pipe esophagus and you're now shortening it. And that reflux, although you're trying to treat that, there's other issues that can occur. So it's not ideal in scleroderma, but can be prescribed under the right situation.
Okay. So then the next is small intestinal bacterial overgrowth. So I'm very interested in how you kind of approach the treatment for that. And then after I have a question from a listener.
Oh, good. Excellent. So basically, when we talked about investigations, and people should listen to that podcast if they're interested, I clinically diagnose it. So I don't do a hydrogen breath test. So basically, bloating, feeling early satiety, a lot of gas, and then severe diarrhea. At the end of the whole diarrhea, you might be better. And over a period of time, it all occurs again, because the diarrhea, you're actually defecating some of the bacterial count. So with that kind of symptomatology, that's quite significant and bothersome to the patient. And I don't think it's irritable bowel, because I'm not going to give antibiotics for regular irritable bowel, which anyone's allowed to have. So if it's small bowel overgrowth by that kind of history, I use an antibiotic, and you can use just about anything. So metronidazole, but not if they drink alcohol, because they can get that disulfiram-like reaction, like an antabuse reaction, which would be bad. But metronidazole is okay. It's not my first choice. Often I use easy ones like amoxicillin, Amoxil, 500 milligrams TID times 7 days with several refills. So use it again when they start getting bad again, because it's cyclical. I like erythromycin, which is often on back order. Why? You'd say, won't that give them diarrhea? It's because it's actually a pro-motility agent as well. And you want pro-motility because that's part of the problem. So erythromycin, when it's not on back order, I don't usually use clarithromycin. You can use tetracycline. You can use many different antibiotics. Cipro works, but we don't like drug resistance with our COPDers who get Pseudomonas and stuff. So Cipro works well, but I don't use it for that reason. And then there's the rifamycin or something it's called that GI uses sometimes in their clinic. It's not reimbursed, and I'm not even sure if I'm giving the right name, but it's supposed to be an antibacterial that's non-absorbed. So that seems neat, because then you won't get maybe thrush or vaginal yeast and things.
So Dr. Hain Kim, who is a scleroderma expert out here in Vancouver, was interested if you have a patient with, let's say, chronic diarrhea and flatulence, but no overt malnutrition. In those people, it sounds like you're comfortable kind of doing an empiric trial of antibiotics. But how about when the symptoms recur, would you use chronic antibiotics?
Right. So again, because I see a lot of these patients, I feel comfortable giving chronic, which might be 1 week a month, or it might be that you're on indefinitely. If you're on indefinitely, I rotate them. I might have my favorite 2 or 3 that seem to help the patient 1 week, 1 week, 1 week, etc., like that. But in general, if you think it's that bad, please get your friendly gastros to help you, because I've learned from them what I could do. So I think I know, but they actually know, because you want to make sure there's nothing else going on. Like I did have one guy only, but he basically developed celiac. He had terrible malnutrition with the scleroderma. And then he got worse, and it was very strange. He got more anemic, and lo and behold, he had something else going on as well. And neither he nor I knew he was gluten intolerant, because he seemed intolerant of everything. Anything he ate was scooted right through him, sometimes even undigested. And their meds might be undigested too. So if they're pooping out their pills, you might have to change the brand, like not the brand, but a different drug in that class.
Right. That makes sense. Okay, great. So we covered Raynaud's previously, so we get to skip Raynaud's today, and we get to go to lungs. And maybe we can start with interstitial lung disease, and then we can talk about pulmonary hypertension afterwards.
Yes. So ILD, 1 in 3 or 1 in 4 of our scleroderma patients, diffuse limited, will have interstitial lung disease. More if you did HRCT on every patient, because you'll pick up some that are probably not ever going to be clinically relevant. But about 1 in 6, it is absolutely clinically relevant. So you have to have a high index of suspicion. So basically, there's debate on when to treat. Less debate on what to treat with. So when to treat, there's 2 studies that have come out over the last year, and they give different results. So you can believe either one or neither. So the one result, why not? So the one result is that if you treat early interstitial lung disease, I won't call it early, it can be early in the time frame, but mild interstitial lung disease with mycophenolate mofetil, you might not get as much progression. Another study showed early treatment didn't change progression, and neither are studies, like there's flaws in both studies. So I think the word's not really there yet. But, if we treat mild RA, maybe it won't go more moderate or severe. If we
Mhm.
treat mild interstitial lung disease, we still will overtreat some patients because probably half of the interstitial lung disease and scleroderma will do them in. The other half won't. So sometimes we don't know who to treat. So the treatment, though, we agree on in general, experts would say it's mycophenolate mofetil again, getting to 3 grams a day, or Myfortic if MMF isn't tolerated or isn't available, like accessed by their drug plan. And Myfortic, 360 of Myfortic equals 500 of CellCept. So you're still trying to orient to that kind of dosing, to maximum dose. Start low, go slow, because a lot of people will get more side effects if you start at full dose. And the side effects, GI, diarrhea, or sometimes they're agitated. They feel ants in their pants, creepy crawly kind of feelings. And I don't know what that means or what it is, but if I go down on the dose, it usually resolves. So I usually start at 500 milligrams BID, and 2 to 4 weeks, if well tolerated, fire off a CBC, ALT, creatinine if you want it, double it. And in another 2 to 4 weeks, if well tolerated, try to get to 1.5 grams twice a day. I do monthly labs. It's all arbitrary what to do, but monthly labs times 3, then Q3 monthly. And I'm really looking at CBC and a liver enzyme, ALT, a transaminase. But if you
Mhm.
wanted to do creatinine or other stuff, you certainly can. And on a CBC, you look at the diff as well. And we don't get too many cytopenias on it.
Mhm. And so MMF as the choice up front, and I guess you get a reasonable bang for your buck in terms of treatment of some of the other symptoms, the skin, as you mentioned. It's perhaps easier to access and easier to write a script for it than cyclo. Who are you going to use cyclo in up front?
So, 2 kinds of people, the really high skin score. So, for those of you who understand the modified Rodnan skin score, you hardly ever see someone over 30. That would be really quite significant skin involvement, because you're not going to get 3 all over your body, but 30 is pretty high. So, the really high skin scores, I might try methotrexate or MMF for like 2 to 4 months. And if they're worsening, as opposed to, I don't expect improvement yet, but if they're worsening, I'm going to switch over to oral cyclo or IV. And that really depends on line access when they're that tight,
Mhm.
local access or your own access to IV or oral. But oral cyclo is okay. That was in the scleroderma lung study, was oral cyclo. Like, it's okay. We use oral cyclo or IV and ANCA vasculitis. So it's not inappropriate to consider one or the other. It's something that I would consider. Or I would quickly get into cyclophosphamide if, say, for some reason we know their lungs before their scleroderma or at the onset were quite good or normal. Say you were 96% predicted TLC, FVC, residual volume, and DLCO, and now you're 80% predicted in 6 months, and it was done right. It was a good test. The person didn't have a cold or something. That is worrisome. And you go 80% predicted, that's like almost, that's normal. That's, but it's a big drop. So
Mhm.
someone with a big drop, I'm just going to move on to cyclo, because not that I think it's way better, but if 1 year of cyclo equals 2 years of MMF, we know it probably is a bit more powerful because they didn't give 2 years of cyclo. And that doesn't mean
Mhm.
I'm giving 2 years. It means I'm trying to do induction for a year or 6 months or something.
So, and I think that's kind of important. And I maybe I kind of missed it when I was in training, but the cyclo regimen for a scleroderma patient, at least as per the trial, that's a full year of cyclophosphamide, and that's compared to like lupus literature or ANCA vasculitis literature, where we're really trying to squeeze that into like 3 months, 6 months. Not many people are treated beyond that with cyclo. Are you still using a regimen that's a year of cyclophosphamide?
I am. If you're bad enough to need cyclo, I'm probably going to add
Mhm.
or switch, because if you're a failure of that, I'm going to move on to somewhat proven, slightly anecdotal stuff beyond it. But basically, that kind of person, I'm not worried about things like lymphoma down the road or bladder cancer, because if
Right.
you're that active, your predicted 5-year survival is not going to be favorable. It would be a 50% 5-year survival.
Okay. So perhaps in your sickest ILD or your more rapidly progressive ILD or your very rapidly progressive skin disease, even with the results of the scleroderma trial, lung trial, you'd still reach for cyclo for your sicker patient. Is that so?
Yeah, yeah. Or I'd give a shorter course of the MMF. I'd say I'm
Right. Give it a
worried
try.
and let's try something else fairly quickly. It just really depends. But I don't shy away from cyclo. It just usually would not be my first line.
Okay. And we kind of hinted at it before, but in terms of the indications, you're using a cutoff of what in terms of a drop in their DLCO, FVC ratio? Is there a good indication where we decide that's a rapid progression? Are there cutoffs? Are there clear guidelines
Right.
there?
So if in 6 to 12 months you have ILD, so HRCT shows you have it, you have a restrictive pattern, and you drop an absolute 5%. That's sort of not going in the right direction, obviously. If you drop 10%, you're a rapid progressor, and that's not great.
And we're talking 10% in DLCO.
I would want to see. I don't want anyone to drop stuff, but I would assume that, right. So I would
Yeah.
assume that FVC, TLC, and DLCO are all going in the wrong direction together. Because in
Okay.
fairness, DLCO could drop if I had a cold and come back up next week when I don't have an upper respiratory tract infection, or some phlegm or something with a bronchitis. So DLCO is a little bit finicky. So if one goes up and two go down, you have to kind of say, what does that mean? And
Yeah.
that's a whole nother podcast that's beyond
Right.
our knowledge.
Okay, so that makes sense. So a change over the course of a year of somewhere around 10% in 2 out of 3, or they're trending poorly, even if they're still within normal limits. It's different than their baseline. Okay, great. How about biologics, antifibrotics, stem cell for ILD, and then we
Right.
can chat
Yes.
about pulmonary hypertension.
Right. So stem cell has the data of severe skin in our earlier diffuse patients, or already having lung disease that I'll call it clinically relevant. The patient might not have dyspnea, but that you can make a diagnosis of lung disease that you think will progress, and moderate skin. So that's the autologous hematopoietic stem cell transplant. That's sort of the data of inclusion criteria. If
Mhm.
we're going to look at biologics for interstitial lung disease in the US, tocilizumab, so the IL-6 inhibitor, was approved for, the wording is something such as preventing progression of lung disease, but they didn't have lung disease, some of them. So the progressors were only a minority of the patients, because it was active early diffuse systemic sclerosis, and if they were under 2 years, they could be in on a certain skin score. But if they were 2 to however many years, I kind of forget, they had to have worsening, or skin modified Rodnan by worsening by 3 points documented, or they had a new area involved on the skin score scale, like now you have truncal, say, or now you have
Mhm.
abdomen involved. So it was a skin primary outcome, which was a P of 0.06, not a very strong effect, but it was monotherapy. It wasn't like you were allowed to escape patients with MMF or methotrexate or azathioprine if their skin worsened by 5 points. So hardly anyone escaped, but more people needed to escape in placebo than active, which I guess indirectly shows you that active was probably doing something. But the skin score change was not very impressive. It was a delta of 3. I think it was like a 6 points compared to 3 points on placebo.
Mhm.
And placebo was the error of the test, or maybe the natural history of the patients. Over a year, you usually don't improve 3 points in early disease, but a placebo effect did occur.
So a delta of 3 points on the modified Rodnan. This is an unfair question, but do you remember off the top of your head with cyclo, like what's the delta you're looking for there?
Yep, I do remember. So cyclo
Of
was,
course you do.
yeah, I do. So cyclo, there are some cyclo studies scleroderma lung study one. So it was a delta of 5.9 or something. So it was a delta of 6
Okay.
versus placebo. And in the scleroderma lung study two, it was 6 points, but they only got treated a year and then nothing on
Right.
cyclo. And it was 3 points over 2 years on MMF. Now, again, these all didn't have high, hot skin. So some of them would be
Mhm.
stable for the lung study.
Okay, so tocilizumab, um, not the studies aren't directly comparable, obviously, different studies, but you get about a delta of 3 compared to placebo for the skin, and cyclophosphamide maybe about 6 for the skin there. Okay. Um, any other biologics that you think of for ILD in particular?
Right. And so I've not used tocilizumab yet for lung. I did we
Mhm.
did have people in the first of the two tocilizumab trials, but it wasn't for lung. It was for skin. And they only in a trial setting have I used it. So but rituximab, so rituximab's off label and that is an issue of access, but there are 3 randomized controlled trials. There's some other case series, and rituximab doesn't always work by any means, but for some people it's quite good. And anecdotally, I think it's better in year 2. So giving a gram IV times 2 Q6 monthly and seeing the skin improve often at the end of a year, 6 to 12 months if we're lucky, and more improvement in second year, it seems. And this is anecdotal now, me saying second year,
Mhm.
but there was a 6 month rituximab versus IV cyclo out of India, and it was better on skin and it was better on lungs. And there was a study out of Japan that was rituximab versus placebo. It's in press, I think, in Lancet Rheumatology, or about to be out in Lancet Rheumatology, but it was just presented at the ACR Convergence 2021 meeting. And that was from Japan and showed this same thing, that obviously, I won't say obviously in scleroderma, but it was better than placebo. And it also had some improvement, like clinically relevant mean change on lungs and clinically relevant change on skin.
Okay, so that's an option then for lung and skin. Do you kind of slot that in as maybe a third line behind MMF and cyclo?
It depends. Sometimes on MMF, I'll add Ritux. Sometimes MMF to Cyclo. And then on Cyclo, I'll go over to Ritux and wonder if I should restart MMF. So you can get the sense I'm
Mhm.
not always doing a monotherapy
Right.
approach, but obviously I'm not putting MMF and Cyclo together.
Hmm. Okay, great. So that was a whirlwind tour through ILD, which is of course a really complicated component of care here.
Other than
Um,
Daniel, sorry, I forgot to say
oh yeah, yeah.
antifibrotic. So
Oh right, of
nintedanib
course.
is for patients with progressive pulmonary fibrosis or worsening interstitial lung disease that is from scleroderma. They have approvals in other ILD like RA fibrosing. So it's not just unique to scleroderma, but the scleroderma trial showed that you worsened on this drug over the next year by a certain amount, but you doubly worsened on placebo. And if you were on
Mhm.
nintedanib plus mycophenolate mofetil, you had the best preservation of FVC, absolute, not percent predicted. It was absolute amount of milliliters they were looking at. And so the best preservation or least amount of worsening was MMF plus nintedanib. Then it was either MMF or nintedanib, and then it was being on neither. So kind of like a dose response, 2 drugs seemed to be better than one drug seemed to be
Mhm.
better than none, but it wasn't, they didn't stratify randomization by MMF. But interestingly and luckily, about half the patients in each side, whether you're on active or placebo, were on MMF. So there's enough power in what I'm telling you to say, although the trial wasn't designed to look at are the 2 drugs better than one, they did find it, and it makes, to me, biologic sense, immune suppression and antifibrotic. And some people think nintedanib has some anti-inflammatory effect as well. And then just briefly, pirfenidone has approval in the US now with a trial stop due to futility because they couldn't enroll well, but it actually became positive for fibrosing lung disease beyond IPF. So if we ever get that approval in Canada, that would also allow a different antifibrotic for our patients. You don't combine the antifibrotics, and you want an expert in that area to help you, which isn't me. I mean, a respirologist.
Mhm. Yeah, I'm trying to, in being aware of those studies, I'm trying to decide kind of the sequence of or the combination of all these different treatments that there seems to be evidence for MMF, cyclo, Ritux, antifibrotics. How do I know when and where and how to combine it, or stem cell, right? These are big treatments that seem like we're likely going to bump into major side effects by using them. So these aren't that benign necessarily. And I'm wondering if you have kind of an idea of where you're going to fit antifibrotics into your kind of treatment approach.
Right. So antifibrotics do not soften the skin like nintedanib did skin scores in those patients on the census trial, which only had systemic sclerosis patients in it. Their in-build trial had some scleroderma patients, RA, sarcoid, etc. So they had a whole mix of people, the other trial. So the skin score didn't budge. So we're doing it to basically try to slow that unrelenting scarring and loss of alveoli, gas exchange in the lungs. So it's really, first of all, it's very expensive. Secondly, it doesn't reverse. It probably prolongs survival, but you're going to go downhill. Whereas at the beginning, I'm trying to get you uphill as meaning an improvement. I want to up your PFTs. I want them better.
Right.
So I think you really want to be sure that this is not it has to be severe enough. But if they're way too severe, we had a patient the other day and now she's beyond getting nintedanib because her DLCO is 24% predicted and her FVC and TLC are like 32% predicted. She's not going to be a candidate because her DLCO excludes her because it was a study exclusion if you're really, really bad. So we would like to have her not go downhill as quickly, but she knows that she's not going to be around a long time.
So it sounds like to kind of find the sweet spot for some of these medications, it's really a combined approach,
absolutely
multidisciplinary, definitely working with your local scleroderma super expert. So
and
your local
a good respirologist, because there are respirologists that are that know a lot about IPF, but there's some that know a lot about IPF and do other ILD. If able, get the IPF and ILD person because then they're used to our immune suppressives and don't want to stop them immediately.
Right. Okay. And then that brings us to pulmonary hypertension. So I know there's been some movement there, some interesting studies. I'm curious about your kind of graduated approach there.
Yep. So treating pulmonary arterial hypertension, which must be proven by right heart catheterization. So it's not on an echo. An echo is your screen, your confirmatory test, of course, is the right heart cath. So if you have pulmonary arterial hypertension, and you have scleroderma, and we think it's from your scleroderma, not say PH, that's not PAH, but from your hypoxia, from your ILD, or PH from your obstructive sleep apnea, etc. We're saying PAH. So if we're treating PAH, it's like RA. Get on with it. Earlier is better. Treat to a target. Add, don't subtract. So it's all that kind of stuff, combination up front, which is sort of how I treat, not sort of, but it's how many of us treat RA, not necessarily in all guidelines, but combo therapy kind of idea. So if you think of it like diabetes type 2 these days, or like RA, just get on, have a high index of suspicion, screen, make the diagnosis. You have to be class 2, meaning some degree of dyspnea to qualify, or worse, to qualify for any of the drugs. There's 3.5 classes of drugs, and you can combine anything other than, I'll call it a half. That's not what they would call it, but Rheum, we don't always have good access to it anyway, because their data were not initially done in our kind of PAH patients. But Rheum, cyclical I don't know, whatever, guanase, I'm saying it wrong, but basically it increases nitric oxide, as do PDE5s. So you don't combine those two. So PDE5s, there's at least 2 on the market approved for pulmonary arterial hypertension. That's the first thing that you might consider, or an endothelin receptor blocker, or the 2 together. Then, so it's often the 2 together, because 2 drugs slow worsening more and get more improvement. Then you treat to a target. If it's not going well, you're going to consider adding a prostacyclin, which could be inhaled. It could be a central line continuous. It could be sub-Q continuous, or it could be a oral prostacyclin analog. And you can do it other ways, like a PDE5 and a prostacyclin, or an endothelin receptor and a prostacyclin. But often it's PDE5 plus endothelin receptor, then add the next. If they don't get, you You want them in the green, meaning good. It's like red light, yellow light, green light. You want people to move from high risk to medium to low. If they're in low risk, you can start monotherapy. And that's like almost too much information for us as rheumatologists. You need the PAH expert team, and they'll figure it out, and you'll keep supporting the patient and sending them back in between if, say, they're in right heart failure or worsening or something.
Got it. Wow. Well, that is super helpful. It just kind of a big picture, 10,000 foot view. Do you have any other kind of tips around treatment that we should the general rheumatologist needs to know?
Well, the patients with scleroderma do have pain, so don't forget about that. Poor mood and frank depression are more common than you might imagine. Well, we would guess it is, but don't be afraid to address people's body image issues or addressing their mood, their pain. And so think the way we would treat chronic pain and mood in our other chronic diseases. Think about that. Think about bone health. Follow their cholesterol, because they do have excess cardiovascular death, but not the same magnitude of risk the way you would in, say, RA. So think of the other lessons you've learned from lupus and rheumatoid arthritis and apply them to your patients. And be a good listening ear, because sometimes with scleroderma, we can't do a lot. We might have a lot of damage. We can't treat their calcinosis, things like that. And just listen and try to be helpful and treat what's treatable. Always treat what's treatable.
Janet, I really appreciate you taking the time. Thanks so much for all that really helpful information, wise tips.
Great, thanks. And I'm going to look forward to our next topic, NYD.
That's right. All right. Well, take care, and I'll talk to you next time.
All right. Bye-bye.
That's it for this episode of Around the Rheum. For questions, comments, and future episode ideas, email us at info@rheum.ca or tag our Twitter account with your question at CRASCRRheum. Around the Rheum is produced by David McGuffin, Dr. Dax Rumsey, and Kevin Baijnauth. We would like to give a special thanks to the Communications Committee and the staff of the CRA for all of their hard work. And of course, as always, an extra special thanks to Dr. Janet Pope. Our theme music was composed by Aaron Fontwell. If you enjoyed your time with us, please give us a rating and subscribe so you don't miss future episodes. You can also share this podcast with your colleagues and spread the word on social media. I'm Daniel Ennis. Thanks so much for listening. Until next time.